Top Bed Talk.
Hello, everybody. Thank you for having me here. I'm Lauren. I'm the dietitian on Dr. Carly's team in Montreal, Canada. And today I'll be speaking to you about malnutrition and functional capacity. What is the effect of multimodal prehabilitation? So besides medical optimization, in our center, we have a trimodal prehabilitation that includes exercise, nutrition, and psychological intervention. Today, I'll be focusing in on nutrition. So, like I said, in our clinic, we have a strong nutritional aspect, and we utilize the subjective global assessment, which is a validated nutritional tool in the cancer population to assess for malnutrition or the risk of malnutrition. We have a comprehensive overview of the patient's weight changes, food intake, as well as nutrition impact symptoms and function, just to name a few. We gather this information and we classify them ordinally into SGA-A, which is well-nourished, SGA-B, moderately malnourished or suspected malnutrition, and SGA-C, severely malnourished. So in our population, although we see that 77% are what we consider well-nourished, we do have about 23% that are either moderately or severely malnourished. That's 1 in 4 patients. We further stratify them according to their 6-minute walk test, which is a great indicator of functional capacity. And what we did see was that those who were severely malnourished had a significantly lower walk test and therefore lower functional capacity. So what we really wanted to know was, does nutritional status predict preoperative change in 6-minute walk tests in colorectal cancer patients following a prehabilitation program? So this was a retrospective analysis, and we pooled data from prehab versus rehab trials, and we isolated the prehabilitation arm only. All participants performed and completed a 6-minute walk test, as well as a nutritional assessment including SGA and PGSG scores, as well as an assessment utilizing a 3-day food recall. So to delve in a little bit deeper into the nutritional intervention, we assess the patient, like I said, and we actually focus in our counseling on a few very important points. So we assess and address any barriers to food intake, okay? We really focus on food first. That's very, very important for us. So trying to meet all macronutrient needs as well as micronutrient needs, but we also do supplement with whey protein to reach the 1.5 gram per kilogram a day. And we also look at managing blood glucose if that's necessary and optimizing body composition. We also support the exercise component of prehabilitation by providing 20 to 30 grams of whey protein post-exercise. So some preliminary results. So the average age of our population was 70, and 59 of them were male. 61% were going for a rectal resection, and 84% of these were performed through laparoscopic measures. The length of prehabilitation was about 1 month, and the adherence was about 83%. So I'd like to orient you here to this wonderful graph. I'm going to just pick this up. Okay, so if we're looking at, this is our total population in our study. If we look at the red circle here, we're defining poor physical status by a 6-minute walk test of less than 400 meters. We define poor nutritional status as SGA-B and C. What we see is that 31% of our total population had a poor physical status. What we see as well for poor nutritional status, that 23% of the total population, of our total population, had poor nutritional status. Now, if we look at both here, physical and nutritional status, in the total population, 12% were both poor physical and nutritional status. What becomes interesting is when we actually isolate those who have poor nutritional status, we see that more than half of them, so 55% of them, have a poor physical status. So although these are not mutually exclusive, it's very important to really pay attention to what's going on here. So we utilize a multivariable linear regression model to look at predictors of preoperative change in 6-minute walk test. And what we saw was that age is a predictor of 6-minute walk change. So every year that you are older, you walk 1.3 meters less. Another significant finding we found was that baseline 6-minute walk test is a great predictor for change in 6-minute walk test. But what this model really revealed was that for each change in SGA-defined nutritional status, there is a large drop in 6-meter walk tests. So somebody who is moderately malnourished will be walking on average 20 meters less than somebody who's well-nourished, and somebody who is severely malnourished, so considered SGA-C category, would be walking 40 meters less than somebody who is well-nourished. So coming back to what we've heard a lot of this morning, what's very important is actually looking at this pyramid of care, because what we saw was that despite these patients going through the same prehabilitation for 4 weeks prior to surgery, there was no meaningful change experienced by those who were malnourished. So although we can give a universal approach might work for somebody who is well nourished, but as soon as we are suspecting malnutrition or there is malnutrition present, it's very important that we actually use a targeted approach or even a specialized approach. And that could be being more aggressive with our food first approach, but also supplementing using oral nutritional supplements, and sometimes going as so far as saying nutrition support with closer follow-ups for greater adherence to what we decide together will be the nutritional intervention. Thank you.
Thank you very much. Is this one on? I'll just stand it. Thank you very much for an excellent talk. We're going to go to Slido for some of the questions, and I think some of those haven't updated. So what I'm going to ask you is one specific nutrition one. What do you do about patients who are overweight, but due to a poor diet might be considered malnourished? Is it just about protein?
That's a very good question. No, it is not just about protein. We definitely want to make sure protein needs are met, but we also try to optimize body composition. So in preparation for surgery, we look at making sure that we can actually reduce fat mass, maintain or actually increase muscle mass while making sure that they're meeting all of their micronutrient needs. And so we look at nutrition holistically, really, in our setting.
Are there any other questions from the audience? Did you want to?
No, I just wanted to add to the last question. As someone who sees a lot of large people, it's not just protein. Invariably, people who have significant obesity have low vitamin D levels. Yep. Invariably, they're iron deficient, and sometimes B12. So you need to factor those in as well. Absolutely. Very good point. Yes.
All right. Brilliant. Thank you very much.
Thank you very much.
Sue's going to introduce our next speaker.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.